Here we are. Welcome to London, guys. Welcome to London.
Yeah, thank you, Lorenzo. Thank you for the organizing committee. It's great to be here. Beautiful location. And we're going to dive straight in. I brought two cases for Paul to challenge. The first one is a typical Swiss case. The woman on the right picture is actually 60 years old in the bottom. So this was a 91-year-old female patient who lives alone, uses a walking stick, still chops her own wood for the fire in her house. She's a little bit obese. We didn't do a radial or femoral or BTK access. With a no PAD. So a previous stent in the left SFA in 2016, previous occlusion also on the left popliteal artery in 2014. She has a chronic kidney disease, she has a knee prosthesis, and she's on clopidogrel and statin therapy. And 1 year ago, she was in the clinic because she's a PAD patient, so we follow her the entire time. Everything was good. Everything was patent, and now she comes to the clinic with symptoms of pain in the right leg just a day before. So it was a Rutherford 2B, acute limb ischemia. She had a pallor, she had pain, there was no pulse, reduced sensibility and motor function as well. ABI was 0, so no Doppler signals available. And this is the CT scan of this patient. And I'm going to start directly also with a question for the access or crossover antegrade or surgical thrombectomy in this case of this patient, where you can see the popliteal occlusion starting now on the right leg. Short, a little bit of calcification, and otherwise BTK, it's always difficult to see, especially when they have calcified vessels. So red flag crossover, green flag antegrade technique, and yellow straight surgical thrombectomy. I saw one yellow flag. Don't be shy.
One yellow flag. Why would you go up and over? What's the pros and cons?
I can do the open femoral artery. I can take the thrombus, and maybe I can do a hybrid procedure.
Good point. Valid point.
Paul, what do you think? Do you agree with him or not?
I mean, I think up and over is going to be, I mean, they're big vessels. So in terms of diameter, so I don't think it's going to be, but it is very steep and it's very calcified. So there is a risk that it may not open up with as you come up and over. The aorta may be more rigid than you think it is. And it does look as if you've got an antegrade window. So, I mean, personally, I would go antegrade.
What about a surgical thrombectomy?
See, that's what you want me to do here, Lorenzo.
That's what forces.
It is. It's what you put me here for. But look, these vessels. I mean, in all honesty, it wouldn't be my first thought in this because of the underlying disease. However, a surgical thrombectomy, you could try it, but you would want probably to be doing it over a wire because you will. If that was your first choice, I don't know why it would be, but if it was your first choice, you need to be able to bail yourself out when it doesn't go well.
Good.
Fully agree.
I think this is a perfect case for our trainees. You know, the superficial femoral artery is open, so just a small cut down, they put a wire, and then they can learn how to do both open and endo procedure. So I think this is a case for our trainees. For sure.
So I entirely agree with you, and that's hopefully where I might be going with this. So just hang on one second.
Can I ask you, how many of you distal pulses in the contralateral limb atrial fibrillation go to the OR without any further imaging or any assessment? Just straightforward for the surgery or for whatever. Or, in other words, is the CT scan or any other imaging a requirement?
So I always use some form of imaging. So duplex is very fast, easy. So we'll see in the next case. We don't have a CT scan in the next case. Otherwise, if there's time, depending on who's on call, because we always the vascular surgeon and the angiologist go straight to the patient. And then we discuss together which therapy we're going to do. But always with some form of imaging, so we know.
Okay, I mentioned that because it's common practice in Spain. You have atrial fibrillation, distal pulses on the contralateral limb, no pulses here, go straight forward to the OR. You agree, Kun?
Yeah, I fully agree. There was sense of loss of sensibility, loss of motoric function. So yeah, based on the fact that our radiologists are a little bit slow and not always available to do this CT angio, I go.
Of course, always the Belgian radiologist.
I go with this case directly to the operating theater. And,
Without ultrasound.
We are performing the duplex to make
with
the
duplex,
diagnosis, but I don't need per se a CT angio.
Exactly. But you're not even doing a duplex.
No, probably in some cases no. It's just no pulses here at the level of the groin. Let's say.
But out of hours, in out of hours, you're not going to.
I mean, like an occlusion here, and it's like straightforward cut down, and that's it.
I think, but what's very interesting is the CT scan looks like much more chronic disease. This, and particularly this appearance here, is just classic
Fresh thrombus.
And so suddenly now that does, and there's a pretty decent looking SFA. I mean, it is gagging for a thrombectomy surgically. If you ask me now, it's now seeing that.
So you would
angio,
puncture the
no, I think no, I've changed my mind.
and then change your
So
mind.
you could do in a hybrid operating theatre. You could do a diagnostic angiogram on the back of your CT and then do a surgical thrombectomy.
I'm not a big fan of
Do you have any
diagnostic
picture of the
angiogram.
runoff?
I know. I'm trying to do what he's
what?
put me here for.
Do you have any picture of the runoff? How is the runoff?
Of course. No, I don't.
Either.
I didn't bring for this case.
Just tell us.
The runoff was good.
It was good. So free vessel sort of.
I have no idea. I can't remember. I have to check the next slide. So, fresh occlusion 1 day prior. So, strategy, I want to do endovascular technique. And it's also what the group of Theo in Athens and in Munich with Kostas Stavroulakis published last year, that an endovascular therapy has the most, has a better outcome, especially when you compare it with strict open surgery. I don't hybrid. If you do this kind of procedure, I suggest when you do it open, you have to do it hybrid, because there is something underlining there, so you have to treat something and don't do blind thrombectomy and then see that it's all good. So in this case, we used the 7 French Indigo system. We saw a culprit lesion after ballooning, and of course, this required, in my opinion, a stent. So in the popliteal artery, I like to use, because of its moving segment, I like to use a superior stent. So we implanted a superior stent in this one here, and the runoff was a 2-vessel runoff.
Thank you. Okay, how many people have implanted a stent here? Green for stent, red for no stent.
No stent?
Okay, because I like
Emiliano?
to discuss that. Because I mean, also the percentage of reocclusion of these cases, I have done also in my experience, a little experience, is quite high if you don't stent, because there's some underlying disease and there's still some thrombosis there. What do you think, Emiliano?
I think it's an acute case, so just remove the thrombus and do medical therapy. I don't think it's a plaque, something like that. It's just thrombus. So, just looking at the.
Okay, we have another noise thing guy here.
So I think you're probably right. If you look at the India series of data from the Penumbra group, about a third of the cases had residual thrombus at the end of a thrombectomy, and so it probably is still thrombus. And so, does it matter? Is it a dissection or is it a thrombus? The bottom line is, if it is thrombus and it reoccludes, you could go back and treat it again. If you put a stent in and that occludes, then you've got a bigger problem. So
you can go back and treat it again.
You can go back in and.
In my opinion, this was a dissection. Green flag dissection, red flag thrombus. So that dissection win. Or we have double flags. Both dissection and thrombus.
Good
Okay.
question.
Bit of both.
I mean, that was the point of my question. You cannot exclude that you have got residual thrombus there. So you're right that this the popliteal, so the superior stent is probably superior, but you should also consider that you can squeeze eventual residual thrombus there. So I would have considered also, because the patient is 95, 91 or quite old, to implant a Viaband there. What do you think?
I'm not a big fan of Viabans anymore, since the data is not that good. I think with despite the fact the fresh thrombus is gone, yeah. Maybe there's some older wall adherent thrombus material, maybe. So in this case, I was not afraid to use a normal stent. If I see,
you have also to consider patient-specific factors. So viable needs adapt for a long time. So in a 90-year-old patient, I think Supera was a pragmatic solution.
Yeah.
Yeah, I think that we must consider the physiopathology of the event because I think it's clear that this is thrombosis on the plaque, is not an embolization. And so, if you don't make nothing on the artery, put the stent, drug-eluting balloon or other thing, the possibility to have a reocclusion in the short term is very high. And so I think if you consider that is an embolism, you can make nothing. But if you consider this case like a thrombosis on the plaque, you must make something for change the outcome of the patient. What do you think?
I have to say something else. If you think about fresh thrombus without an underlying stenosis, the most times the thrombus is sitting on a bifurcation or a trifurcation. So it's in the common femoral artery or it's here, PTK. So I don't think this, with just that part that was fresh occluded, this was an acute on chronic probably.
And it's you see already the calcium anyway. Which
you can see it on the, I mean, you can see it, I'm supporting him, you can see it on the CT scan. I mean, it's acute on chronic.
Thanos.
Michel and Paul, I mean, isn't this the perfect case to use either IVUS or extravascular ultrasound?
I wanted to go there.
We're starting to do an ALI case without having some form of ultrasound-based assessment of what we've done to the lesions, right?
So Thanos, I was just going to say exactly that, because I think it maybe in this case it's not quite the same, but one of the things I find very difficult to understand often is it a dissection or isn't it? And if it is a dissection, this phrase flow limiting, is it a flow limiting dissection or not? And obviously with IVUS now you can start to grade these dissections and have a better understanding of what needs to be stented and what doesn't need to be stented.
Cool.
I think
you're shaking your head. Why?
No, I'm not. I totally agree. But I think here it's not so important if it is a organized thrombus or a fresh thrombus or remaining flap or whatever. You need to scaffold it, in my opinion. And I agree with Supera, but even better is the Rensen of Terumo, where you have a dual layer mesh. And so it's look-alike, interwoven as a Supera, but you have this additional dual mesh, so to be sure 100% that you don't have distal embolization after the scaffold implantation. So that's my recommendation. And by the way, if you look at is it a Belgian patient?
A Swiss patient.
Because if you look in the next slides to your posterior
tibial,
you're going to see that the Swiss patients are almost the same as the Belgian patients. Look at this posterior. Can you play the movie? Look there. How beautiful.
That's why I moved there.
There's a hand here. Oh, sorry.
Just a short question with the Supera. I mean, you implanted the Supera without prior angioplasty because you wouldn't angioplasty this residual thrombosis, isn't it? So you must feel very sure that your Supera will open up.
Yeah, but what I also saw, because we had one colleague who did his first Supera case, and he effed up, you know. He really prolonged it extremely all the way up until the common femoral artery. So then they called me and I was like, what did you do? So what I did or tried to do, but now I've seen your technique by just pulling it out. I ballooned it extremely, and you see with the Supera, when it has the room, it goes back to its nominal size.
When it has the room.
When it has the room. When it has the room.
Yeah.
Yeah. So
the only thing is, I think this is the lesion. When you start ballooning, you will have distal embolization. So that would be my only concern here.
I mean, the question is, why are you putting the stent? Is the stent to treat the underlying stenotic disease, or is the stent to pin any residual old thrombus back? If it's both, then maybe it doesn't matter quite so much. But if it's to definitely treat the underlying lesion, you may not be so good if you haven't pre-dilated it.
Yeah. So I post-dilated, but it was okay.
I was just thinking about the patient. She was 91 years old. She has no symptoms before this acute event. So actually, as a chronic disease was not having impact.
But Antonella, you also live in Switzerland. You know these old patients, they walk through the pain.
No,
You know,
yes.
she's chopping her own wood.
Let's assume that she, according to
So let's assume she can walk 1 kilometer and then has pain.
Yeah, so
because
at the
there was a
the chronic
40%
disease
stenosis.
was not having impact on
Yeah.
his life, her life. Sorry. And so at the moment you remove the thrombus, the fresh one on chronic, you left a chronic one that would have led her to be Radcliffe 1 maybe. That is something that it was, the therapy was underestimated because I saw that she was on clopidogrel only, so maybe she has problem with ASA, with the other antiplatelet drug, so maybe she can have benefit after this first removal of a dedicated best medical therapy with maybe Xarelto if she's got problem with ASA or something like that.
So are you suggesting to remove the thrombus and not
Leave
to
it
stent and just to anticoagulate?
Also, yes.
I have one supporter in the room. That's great. Okay.
Congratulations.
Thank you very much.
No, but it's maybe she can be a rather for one,
Yeah.
or even and we avoid the risk in a 91 years old patient of restenosis of a stent. In example, I would not go for a Viabam because if she come back to all of a sudden to occlusion, she have a brutal symptoms. So.
I mean, I think also if you put a slide before, we can go with one case. We don't have to do two cases. It's better to
but the
discuss.
next one,
He
the
wants
next
to
case
do
is
his
very
next-
interesting. Yeah, it's very.
He thinks it's a slam dunk, the next one.
But I think like it's also that genicular artery there, that if you cover with the Viaband, then I think this could be a problem. If you show that genicular artery, and if you really want to stent, probably, I don't know, it could be that you land there. What do you think, Aurelio?
No, I also vote for dissection, but it's a 91 years old, so it's chronic disease. What would you think about drug coat balloon, this portion of the popliteal?
Then you have the same problem if with eventual distal embolization.
Yeah,
And I think that Spera here has great results. She's 91 years old. She will not, probably, maybe not live for 20 more years. There's a question in the back.
Even this week.
Just, Michel, one quick one.
Peter.
So this lady made it 90 years without thrombosing her popliteal, and for some reason it suddenly thrombosed. So her coagulation profile could have changed completely. I mean, she may have a new cancer, she may have something else going on. All these people are on heparin afterward because that's what we do. So, I mean, I like the idea of not putting in an implant unless you absolutely have to. And because all of these patients, you rarely get a perfect result on an acute. You almost always end up doing some more imaging. For her, I would just do a duplex probably the next day or, the next opportunity rather than put an implant right now because something may have changed for her physiologically.
Okay. Valid comment.
And along the same lines of medical therapy, if you did IVUS and there was not a flow-limiting dissection, how about low-dose Xarelto based on COMPASS and the COMPASS data and COMPASS and what's the other trial? I forgot the name of the trial. But 2.5 milligrams of Xarelto BID with aspirin.
Without putting an implant here.
Without putting an implant, correct.
So we put her on Xarelto 2.5 afterwards.
You see,
but
they've
with
all,
the
had,
implant.
they've all had a chance to begin to think about it, and they're realizing that maybe a stent's not quite such a good idea.
Well, I think it was a good idea to put a stent. If it was my mother, I would have put a stent as well.
Okay.
If she,
Good. So let's.
What do you think?
Yeah, I personally think a stent is also a good option, but it's nice to have this kind of debate, and maybe to change our mind slowly. Good. Case 2.
Case 2. We still have 11 minutes.
Yes.
Another old patient, 82 years old, so the male don't live as long as the females.
Spring chicken.
He has a pain in his right lower leg since 3 days. So 3 days before he goes to the clinic. We only did the duplex ultrasound. He has a popliteal occlusion P3 level. So Rutherford 2B on his right leg. We had a motor function of M2, M3 on his foot, and some sensory impairment. Previous pulmonary embolism, previous deep vein thrombosis. He has an arrhythmia absoluta diagnosed 1 year prior, and he is on coumarin therapy. But as you can see, at the INR level, it's non-effective at the moment. So this patient, P3 disease, same question as we did before. Red flag crossover, green flag antegrade, yellow flag direct surgical thrombectomy. Emiliano, I expect a yellow flag. Oh.
No, but there's some yellow flags here. Tell us more about why you go thrombectomy, and maybe Paul can...
So there's no CT?
Do you have a flag?
No, I haven't got a flag.
No CT, only duplex ultrasound.
Okay.
Thank you. So, yeah, in the absence of any previous imaging, based on what we have so far, it looks like this 82-year-old man with what looks like a high risk for throwing off clots has thrown off an acute clot. And our practice is that when we go antegrade, we have high risk of thrashing, so we refer for a surgical opinion of, would you like to take this patient to theatre for a thrombectomy first?
Paul, would you do a popliteal cut down? What would you do?
Wait. Wait. No, don't answer this yet. Don't answer this yet.
Referee.
Just wait. Just look at the images. These are the images. These are the images.
Okay.
Because then there comes a slide with a question. So this is the clear SFA was good, and then you have the complete occlusion of the P3 segment. There's a little bit of a posterior tibial artery runoff there.
High takeoff of the popliteal, which is actually at the moment is the main vessel to the foot.
Exactly, at the moment. So these are the images. Everybody saw the images. So the question is now again, let's assume we do an antegrade approach for all the ones who did a green flag, and all the other ones can also do. What we do next? Do we do a pharmacomechanical thrombectomy in this case? Do we do an aspirational thrombectomy with indigo, or do we do the Rotarex in this case, so 3 days old, or if we don't have another flag, so we raise your hand if you do just put in the catheter, do some thrombolysis, and look at the next day. So we have a mix of everything. Does anybody who wants to comment? Paul, you want to comment? What will you do?
3 days, but was it definitely 3 days? I mean, I think that's the point. Is it? And this patient is very prothrombotic, having had Ps, DVTs in the past. I mean, we don't use a huge amount of lysis in our unit because of it. I mean, and I think it's not about the actual lysis itself, but it's about where the beds, the costs, the nursing, etc. So our use of lysis is low. I mean, it's either going to be surgical, and I think my point here about surgical thrombectomy now is what does that actually mean? Because to make a cut in the groin, to sling the vessels, to give some heparin, and to do a Fogarty embolectomy is pretty old-fashioned. Surgery now, to me, is a hybrid procedure in a hybrid operating theatre that would involve a wire, an angiogram, and potentially some form of mechanical thrombectomy. And personally, I would go for. I mean, I realise I'm doing your job for you, but I now would be doing something like a penumbra. I don't have Rotarex, but I've heard good things about Rotarex. But penumbra would be where you were heading, because that is a surgical nowadays, a combination, because you may need to deal with the groin disease. Equally, this patient may need fasciotomies. That's all surgery, as well as removing thrombus. So I think this Lorenzo asking me to talk about surgery, I think what he's asking is about a very old-fashioned, just a straightforward Fogarty embolectomy, and I'm not sure nowadays that many units are doing just that.
Many units are doing that. Depends if you say that it's the right path to go, or is some old-fashioned, regurgitation from a pure surgical blind thrombectomy.
But let's ask another question. If you have 1 second, red flag if you have an over-the-wire Fogarty catheter, and green flag if you don't have an over-the-wire Fogarty catheter. So there are some green flags who don't have an over-the-wire Fogarty catheter. So how are you gonna? So my advice is for everybody to have at least an over-the-wire Fogarty catheter available.
Craig.
Do you want to comment, the two of you, on the time frame in which you would not use indigo? So
I don't know yet, honestly. 10 days.
Getting results out past a week.
Yeah, I mean, we cleared a CRAB limb that was 10 days old the other day. So, and it worked beautifully
with the lightning. Yeah.
With the lightning.
Nice.
So, but I don't know yet. We haven't done enough of it, but I'll let you know.
I don't like to use it when it's more than a week. Yeah, because there are other devices that are more effective in that way.
Let's see then.
So next, the other question is for Paul as well, and for all the vascular surgeons in the audience. You've seen this kind of occlusion at this moment. So the question is, which axis would you do for open surgery? Would you do a femoral axis with the Fogarty, or would you do the directly P3? So red femoral, green P3 axis, or yellow something else?
A red one.
Who won? Was there a yellow flag, or was this just the lighting?
Yes.
Only green and red, eh? Okay.
I think for me, that as a vascular surgeon, it's easier to perform a cut down in the femoral. You can do the vessels with your wires and your Fogarty guide wires, so it's easier.
I mean, the danger of a femoral embolectomy is that you will only get one vessel running, and because you may get your Fogarty will go down one, and you may not be able to steer it down any other. A popliteal cut down is, depending on the size of the leg, 3 o'clock in the morning. It's a pretty unpleasant experience trying to identify the origin of the 3 different vessels, trying to poke a catheter down each one. It's personally, I don't find that a fulfilling 3 hours of my life. But that would be what would give you the best clearance of all 3 vessels if that was your choice. Yeah. And personally, and I realise I'm going off message here for the surgical side, but that to me is the one I think is going to be one of the biggest benefits of mechanical thrombectomy of penumbra, is that you will be able to avoid these low cut downs around the popliteal, and you'll be able to guide your catheter down each of the vessels. But if I was doing this and I didn't have anything else, then I would do a popliteal cut down to clear this.
Good, excellent. So what we did was we did a aspiration. And which was actually the better, or looked like it would be the better vessel, was the tibial artery, the anterior tibial artery, but the posterior was now patent. It's still diseased, and you can still see the shadows of the thrombus material in the posterior tibial artery.
Is it not the peroneal? Because I thought that the posterior tibia was taking off more proximal. No.
I think the fibular or the peroneal artery is taking off here.
Okay, so there was another vessel which was coming off.
This was the posterior tibial. Posterior
in B3. In B3 there was another artery which was coming off.
No.
You want to bet?
Michel, which catheter did you use for aspiration?
Sorry?
Which catheter did you use?
The 7 French Indio catheter. So let's have a look and see which artery are you talking about? The collateral.
Is it the collateral?
That's the collateral.
This here.
No, he means this one. He means this one. This is collateral.
Collateral. Sorry, it looked like a naive.
You should have taken that bet. He said, "Do you want to bet?"
Yeah, but he lost so many bets against me, so I'm not gonna.
I didn't say it.
So and then there are 2 options. You can go in with a 3 millimeter catheter and go into the vessels itself. We stopped and we put in a lysis catheter. Question.
I was wondering how low can you go with these devices, and can you consider just to use a regular thrombosuction with a catheter with a fatlock on it as an alternative?
Well, the only issue that I have with a normal catheter, an aspiration catheter, is that you always have to pull it out and go back in and pull it out. So you have to you can go down with a long sheet and try to aspirate. But you can't have a continuously suction. So my hope is to by continuous sucking the thrombus out. You can't go into the tibial arteries with a 7 French. You can't.
There is, if I may,
there's a 3 French.
Do a remark. If you use a smaller catheter, so they're quite cost-effective. 5 French guiding catheter, you can go down to the pedal artery, and you can clear all of them, or the two of them.
Okay.
Or you can use a smaller catheter from penumbra, like a 3-cut, 5-cut, and go down to the pedal arteries. Maybe an alternative.
Also an option to save the lysis then.
We should try to avoid lysis if possible. In an 80-year-old gentleman, there is a small risk, but there is always a risk of...
I think I agree with you.
You can use
we have to save on lysis. Don't avoid lysis.
No, I think
so. I don't want to do 3 days, 3 days of
If
lysis.
possible, I would try to work mechanically without lysis. It's not always possible, but I think in most cases.
But I don't think in these cases here, where you've got all this little bits of residual thrombus in the tibial artery, I don't think you can clear that surgery. I think if that is fresh, lysis.
Surgically, probably you can't, but with the interventional systems we have available, you may be able to clear 90% of that.
Anyway, let's see how it went.
So what happens, of course, is after.
Yes, Antonella.
Going back to the question, actually, if you have an real acute patient with good artery, I personally go to the tibial artery with the 7 lining. I completely shift. I don't use almost anymore the 6 because it doesn't change that much on 0.3 something. And so for me, it's more effective. I can clean out the tibial with that. Of course, you cannot when it is acute on chronic because the plaque is going to stop you, but it's not that difficult to reach down to the foot. And I did it also for bypass, and it actually worked.
So I've certainly heard of the 7 French being used in the tibials. You have to have flow though. It can't completely obtund the vessel.
Exactly. It's just something mental because you need to go with a 7 French. Of course, it's completely different. It seems quite big, but actually, where can go a 6 can go a 7, and you are more effective, of course. But in a really acute patient with healthy vessels.
Okay, so for time's sake, so after 3 hours of lysis, the intermediate care unit called and said, okay, it's an alarm of the lysis therapy. So we did a recheck after 3 hours, and you can see still some residual thrombus. So we continued the lysis, because we now saw that the anterior tibial artery is coming more than before, and then the next day we could stop the procedure because we had a 2-vessel runoff with a very nice anterior tibial artery going all the way down to the foot. So here we stopped, and then we discharged him again with Eliquis or apixaban 2 times 5 milligram, and 1 month later he came back for control, and he still has triphasic signals in his distal tibial anterior artery. So he was happy.
I think this session was great because we had so much discussion, not only on thrombectomy, but also to what to do, in case of lysis, in case of stenting. I think this was a very interesting one. I think there's not a winner. I think we have seen how many options there are. I think that we are all winners because we had this kind of huge discussion. So congratulations to both. And now it's time for coffee break. So please go down and have a little coffee. Thanks a lot.